Well, this service has been running for 10 years now, so obviously has developed over that time. It is a nurse-led service that looks primarily at the management of heart failure patients, right through from diagnosis through to the terminal stages of the illness. We run a mixture of clinics within the hospital setting and also do home visits for patients who are unable to get up to the hospital. And certainly seeing people at home gives you a very unique insight into their situation and often how they're managing with their symptoms. Within the clinic, we look at drug up titration and initiation of medication, and the whole gamut of lifestyle issues around fluid restrictions, salt, low salt diets, exercise, health promotion generally, smoking, alcohol avoidance for some patients, and really tailor all of that to the individual. Certainly around medication, I'm a nurse prescriber, and that means that I can actually initiate drugs that meet the criteria as far as heart failure medication. Being a non-prescriber, officially I can prescribe any medication, but within my professional scope of conduct, that should very much be around my knowledge, which is obviously heart failure and some of the peripheral sort of drugs around cardiac management generally. As I say, I can initiate drugs either myself by giving patients a prescription, or obviously we also do it through the GPs as well, and that's very much around keeping the GPs in the loop and making sure that they're aware of what's going on with their patients, because we need them to continue that medication possibly, for the rest of the patient's life.
Now the issue about we were talking off camera about empowering patients, taking responsibility, which you said is quite a mainstay because self-management. Can you just tell us a bit about how they self-manage and how your role in encouraging that?
What we know from quite a lot of the research that's been done on nurse-led heart failure services is that a lot of the success as far as the patients are concerned around keeping them out of hospital and keeping them well is around them learning to manage their condition. And there's a lot of things that people can do to manage their heart failure symptoms and the condition generally. The first thing we teach all our patients is to weigh themselves every day, and to obviously note any sudden changes in their weight. Also to look for any new swelling or any changes in their breathing, particularly some of the more subtle signs such as starting to wake up at night, being out of breath, noticing that maybe climbing the stairs is taking them that bit longer. And if any of those symptoms and the weight start to change, then we would get them to increase their diuretics. And we actually have a written document that is given to the patient that shows them how to step up their diuretics, and equally, at what point they should be telling us and letting us know that, things aren't going as planned. And certainly for us, we normally say if after 3 days of their increased diuretic things haven't improved, then that's when they need to let us know. And then we can advise further. We can obviously arrange to see them, and we normally would do that within sort of 24 to 48 hours, and we can then make further adjustments as necessary.
Because I was wondering whether in empowering them in that way, if they then can't access the health services very quickly, so how do you do that? Do you have a drop-in service?
We our diaries tend to be fairly flexible in that we can often go and see someone. If they ring up in the morning, we'll go and see them in the afternoon.
Go to them?
Yes, quite often go to them. We only have a couple of clinics within the hospital each week, and so sometimes it's just easier to actually say, well, I'll pop in and see you while I'm out seeing other people, rather than trying to find time and space to see them within the hospital setting. And obviously if they're not feeling well, it's often difficult for them then to get up to the hospital, especially if they're relying on public transport and not feeling so good. So we would go in and see them, assess them, and obviously decide, is it definitely their heart failure symptoms, and what's the next step? We would be able to check their blood pressure, check bloods to make sure that, you know, they're not becoming dehydrated, etc., and then make a decision based on those things as to whether we need to make further adjustments in medication, or obviously whether the patient actually needs to come into hospital.
I can hear your clinics are well underway today. Do you have a role in the initial diagnosis? Because I was just thinking while you were talking, there may be a suspicion from the community doctor, or as we know in general practitioner, that this patient does have chronic heart failure, but it's I'm led to believe quite an over-diagnosed condition. So would you provide a confirmation in your role through I don't know, peptide testing or whatever? So would you be involved in the initial diagnostic stage?
We're not currently, however there are moves afoot at the moment to develop very much a community heart failure service that will be looking at possibly one-stop clinics for the diagnosis of heart failure. And certainly one of the measures they're looking at using is peptide testing, because, you know, as you say, we know that it is very much an overdiagnosed problem. A lot of people will have swollen ankles and be a bit short of breath, particularly as they get older. But not all of those will have heart failure. And certainly peptide testing alongside ECG monitoring is hopefully going to be the way forward, so that all these patients don't get sent in for echocardiograms, which are obviously a lot more expensive on you know, the NHS budget than the peptide testing and an ECG would be. And then, you know, the GP can direct the relevant testing in the right direction. So if the peptide's negative and a normal ECG, they need to be looking at another cause for the patient's symptoms, whereas if they're positive, then yes, they can send them in for an echocardiogram. So we actually at the moment see people once they've had a confirmed diagnosis, normally by echocardiogram.
Right. I mean, how is peptide testing pretty sensitive in terms of ruling out? I mean, I'm led to believe it is, but as a specialist, because what you're saying is, you know, you can't have an echo in every community practice, but you could blood test.
That's right.
More locally.
That's right. I mean, certainly peptide testing is a little bit almost controversial in that there isn't a sort of cut-off point in that respect for the levels, because they are affected by an awful lot of things, certainly renal function, age, ethnicity, etc. But there are levels below which it is definitely negative, and you know, you can certainly say there is no likelihood of that being heart failure. There is a sort of, on the other end, obviously the very high results with an abnormal ECG and all the right symptoms, you can say is almost certainly going to be a diagnosis of heart failure. There's a bit of middle ground, unfortunately, where, you know, those people probably still will need an echocardiogram, because, you know, it's a bit equivocal on their results.
And also thinking the future, I mean, I'm sure as, you know, big centre with a big local population, they're pushing different medications and all sorts of things that are happening. What is likely to be happening that's going to change the management of heart failure?
There haven't been any huge changes in heart failure management for a good number of years now. I mean, I think probably, you know, the most recent big change was the introduction of beta blockers, which is now well over 10 years ago. There are a few things sort of on the horizon. Certainly now eplerenone is being used very much as a primary drug for people who've got heart failure symptoms post myocardial infarction. And the other one that we're starting to see being used more is ivabradine, or Procorolan as it's also known, as a heart rate reduction medication. It's been used in angina for some time, particularly as an alternative to people who can't have a beta blocker, so asthmatics, people whose blood pressure is very low, because it independently reduces the heart rate without affecting the blood pressure. And the SHIFT study has actually given us some evidence now to say that it's probably going to be very beneficial for heart failure patients, and that in fact their heart rate is almost an independent risk for heart failure and the symptoms of heart failure. and although it's currently off licence, we are starting to use it under the cardiologist's guidance, and we're seeing some very good results where we're reducing heart rate and people's symptoms are improving. So that's quite probably one of the most newest drugs coming along that hopefully will have some benefit. And I think other than that, in the way of medication, the other thing is obviously device therapy, which is becoming more and more prevalent. And certainly we're now looking at using biventricular pacemakers much earlier in a patient's progress through heart failure. You know, they have up until a few years ago primarily been used for the sort of grade 3 and grade 4 heart failures who've got a lot more symptoms.
That's the New York
Heart Association classification.
Yeah.
So really patients who are very symptomatic despite maximum medication. Now we're looking very much that, you know, we should be using them for patients who've got much milder symptoms, and hopefully that is going to prevent further deterioration or certainly slow it down and give people not only more quality of life but, you know, some improvement in their life expectancy as well.
And we can put some references at the end to all of those things that you talked about. Just finally, evaluating the service, because it's an interesting argument that maybe we should move away from patient satisfaction to patient's experience, because the argument could be presented that patients will be satisfied sometimes with just seeing a nurse, somebody at an earlier time point, etc. So there's all that debate about looking at the patient's journey, experience, etc. Do you evaluate your service at all?
We do. I mean, we do patient satisfaction surveys, which, you know, we found is very beneficial. But I think you're quite right. There are a big group of patients who actually benefit from you going and seeing them, even if you don't actually do any intervention in that respect. It's the support, I think. You know, they do feel very isolated and very alone with their diagnosis and very frightened often, and not only themselves but their carers as well. We also look at our readmission figures around being readmitted back to hospital after a diagnosis of heart failure. And we certainly know that once our service is involved with people, that does reduce the admissions to hospital. And some work that was done a few years ago now actually showed that was by up to 50% reduction in readmission after the initial diagnosis. We run a database which actually obviously gives us lots of figures around where our referrals are coming from, as I say, people coming back into hospital, what areas of the borough they come from, as well as which specialities are referring in, which is all useful information to actually be able to develop the service.
I mean, two final points. How, I mean, your service is 10 years old, how has it worked with the medics? Been very accepting of the role, or have there been challenges?
There have been challenges, yes. We're very lucky in that our cardiology consultants are very supportive of our role, and certainly within their teams they really do encourage their doctors to not only refer to us but also to actually listen to advice, and we actually try to go on the wards quite a lot to see patients that have been referred to hopefully aid with their treatment so that their discharge is that bit quicker. And, you know, if they know that we can see them fairly quickly post-discharge, very often they're a little bit more encouraged to allow them home a bit earlier because they know someone's going to be following them up. There have been challenges around some of the medics not being as accepting of being, you know, given advice by a nurse, and I think again that's just about time and keep sort of plugging away and, if you like, proving your worth. And certainly with the GPs, I think that's where we've won them over in the end, is just by actually showing them that we know what we're doing, and that the community doctors, and just showing them that actually there is a benefit to us going and being involved with their patients. You know, they get a letter every time we see them. Every change we make, they're notified, you know, immediately. So they're kept up to date all the time with what's happening, and that's certainly one of their quibbles, if you like, very often with secondary care, with the hospital, that, you know, sometimes they don't get the information or don't get it quickly enough.
And just finally, anybody around the world setting up, and obviously, you know, some of the issues are country specific, profession specific, depending on, as a nurse, how it's structured in your country. But any tips on setting up a service from your own experience?
I think certainly from my experience, it's best to start small and build. Don't set yourself too huge a goal. You know, don't say, well, I'm going to see, you know, a couple of hundred patients, you know, on my caseload within a few months, because you need to build it up gradually, so that you give the quality of service rather than just the quantity of service. And sometimes that's hard because we're always being asked to prove ourselves and, you know, prove our worth as a service. Obviously, good communication is essential, and as I say, with your community doctors, with other doctors within the hospital, inter-hospital, you know, I mean, we deal obviously with tertiary centres as well that do the surgery, etc. And that communication is absolutely vital. And empowering patients to be communicative as well, so that they have got a copy of their letter, you know, that you've sent to their doctor. And therefore, if there has been a problem and the GP hasn't received the letter or hasn't acted on it, the patient's got the empowerment to actually go and say, well, look, this is what happened at my consultation. You know, I'd like the prescription, or I'd like this action taken. So I think certainly getting people on board in that respect by, you know, letting everybody know what you're doing is absolutely vital.
Administration, do you do your own letters?
We do, unfortunately. Some services do have administration, which is great. Our database actually allows us to do our clinical letters via the database, which is a big help because, you know, we've got to put the information on the database anyway, and then it automatically populates into a letter, which is really useful. But we do all our own appointments. There are advantages and disadvantages. Obviously, the disadvantage is that it's time consuming, it's taking you away from the actual clinical work. The advantage is that if I need to see someone in 2 days' time, I can fit them into my diary, whereas an appointments clerk or administrator probably wouldn't. I know that Mr. So-and-so lives 2 roads down from the other person I need to see, and so I can fit them in, or I know that equally they live the other side of the borough and I can't do it on that particular day. So, you know, there's pros and cons of both ways, I think.
Okay, thank you for talking to us.
Thank you.